here's the first question. And so I'm sorry that we can't get to everybody's questions. There are so many.
There's too many good questions.
Too many good questions.
And so you'll have to come back again next time.
What significant evolutions have you observed in the discipline of CBT over the decades, and what do you think is still on the horizon?
So when I first got started, we didn't call it CBT. And so I first started working on depression. And then I found that the people with depression did well. And so I had founded a clinic at Penn, and we started having anxiety patients as well as depression. We called it the Mood Clinic. So then I wondered, is it possible that this strategy could be adapted to anxiety? And indeed it worked. And so first we wrote a book on depression, then we wrote a book on anxiety, and then we had a lot of suicidal patients come in. And we wondered, can this prevent suicide? So we wrote a book on suicide. So all along the line, as new conditions appeared on the map, either my group or other groups or other individuals, professionals, would try out cognitive therapy, but adapt it. And in most recent years, it's been adapted to chronic, long-term schizophrenia. And then I figured, well, now we've covered the waterfront, and people would ask, is there any condition where cognitive therapy does not work? And I would say, okay, it doesn't work on Alzheimer's, and it doesn't work on autistic children. And then I see, and when we review the literature, that it has an impact on Alzheimer's, and it also has an impact on autistic children. And the common denominator is the beliefs that people have. So people with Alzheimer's have a lot of dysfunctional negative beliefs, which aggravate the situation and makes the people far more disabled than they have to be. Oh, and one other condition was metastatic cancer. And so cognitive therapy has been used in the terminally ill, again, dealing with the people's beliefs and automatic thoughts and their general purview of their condition. And the most recent thing that I heard was that cognitive therapy's been used with autistic children. However, we'll have to have a workshop at some future date where we can discuss how it works with these other conditions. So people often will ask, is there anything where cognitive therapy doesn't work? And so I'm afraid to answer that question anymore.
Well, and in fact, it doesn't necessarily cure all these conditions,
no.
But it certainly helps people cope.
It helps. And in the future, I think that you're going to find that in the future, more and more medical conditions are amenable to CBT. So if you take diabetes, only about 50% of people with diabetes follow the regular regimen, which is diet and exercise and taking their insulin, and they don't do it. And it turns out that they have various beliefs, and Rob has talked about procrastination being a major reason why they do that. Well, cognitive therapy can help with all of these medical diseases because the people simply do not follow the prescribed regimen that they have. And so cognitive interventions are very helpful in that respect.
So you've talked about the evolution of some of your work from depression to anxiety and many others, chronic pain, personality disorders, suicide, schizophrenia, substance abuse. Can you talk a little bit about the role that research played in the development of these treatments and in testing the efficacy of the treatments?
So whenever I come across conditions: depression, anxiety, OCD, personality disorders. What I first did was develop a questionnaire so we could identify the conditions. So we had the depression inventory and anxiety inventory, personality questionnaire, and so on. So in order to do research, you have to identify these conditions. And as it happens, the psychometrics were very poor for identifying particular conditions. And so the next thing I would do, and this often was after I treated a few patients with that disorder, was to see what are the crucial beliefs that go with the disorder. So, for example, with depression, a common belief is, I have a headache, and therefore I will never get better. This is just a sign of my deterioration. The anxiety person, in contrast, says, I have a headache, I may never get better. And so they leave open the possibility. And so they get anxious because they're worried about the future. In depression, the future is already foreclosed, so that it's already, they're done in at this point, and so on. And so what I did with each of these conditions, and then various colleagues continued on with other conditions, is to see what are the basic beliefs, what are the automatic thoughts that go with the condition.